Clearly, we need to start a dating app for like health and housing. Just kidding. Okay, folks. So I think I heard an amen when we heard from Camilla that we're trying to function in dysfunctional systems. So here to sort of help us in the last panel of the day, we're going to talk about policy implications and maybe how we can make some of these systems more functional. Before we get to our final panel, I just want to welcome Shannon McMahon, who is Executive Director of National Medicaid at Kaiser Permanente, to share a couple of thoughts with us. Welcome, Shannon.
Sarah, thank you. Thank you so much. And thanks to the Alliance. What a great meeting. Lots of familiar faces and new faces. Terrific work. In my role at Kaiser Permanente, I do a lot of work with our payers and our payer team, our providers, bridging those conversations and engaging in the work on social determinants of health. I wanted to talk a little bit briefly about work that just launched at Kaiser Permanente called Thrive Local, where we're pulling together a resource directory, networks of community providers, and data to bridge those social determinants and bring to bear within our practice, within our work, services and connections to social determinants. Part of that work involved doing some on-the-ground research in the regions where we do business to understand really what the communities are thinking about, what their concerns are, and wanted to share just two quick nuggets that frankly affirm everything that we've heard this morning. First and foremost, that Dr. Wadwa just a minute ago mentioned higher income people, which I think is something that hasn't really resonated, especially for someone like me who's spent their entire career in Medicaid. Unmet social needs are prevalent even among families at the highest income levels, $125,000 a year or more. 40% of these families in the survey we did experience at least one unmet social need. So this isn't just about Medicaid, and I really think that what Sandeep said about large employers is something that, from my perspective, is kind of the next big space. Health is not determined in a doctor's visit alone. Americans are united in their belief that stable housing, balanced meals, reliable transportation, supportive social relationships. Haven't spent a ton of time on that today, other than through the faith lens, but I think that's a super important thing for us to take away. So looking forward to the policy conversation, lots of good Medicaid folks coming up next. So thank you, Sarah and team, for the opportunity to be here today, and looking forward to the next phase of this work.
Thank you. Thank you so much, Shannon. And before I introduce our next moderator, I just want to take one moment to thank the Alliance team. If you're on the Alliance team, or can you please raise your hand? Come on. Thank you. We have a team of 9, and they do incredible work, so thank you. So here to moderate our final panel is Liz Wroe. Liz serves as a principal at Leavitt Partners, where she manages complex multi-sector alliances and advises clients on the impact of federal and state healthcare issues and how to effectively engage with policymakers. She recently served as chief counsel and director of outreach and coalitions for Chairman Lamar Alexander of the United States Senate Committee on Health, Education, Labor, and Pensions, as we all know, the HELP Committee. And so Liz is going to lead the panel in a conversation about next steps for the policy community. Thanks, Liz.
Great. Well, thank you all. It is really wonderful to be here. And one of the exciting things that I've gotten to work on at Leavitt Partners is an organization that we work with, the National Alliance to Impact Social Determinants of Health, NASDO. So there's a number of NASDO members in the room today, so we appreciate all of your work in this space. I feel a little bit like, I don't know if anyone's seen, David Letterman has a new Netflix series, which is My Next Guest Needs No Introduction. My next guest needs no introduction. We have Congresswoman Allyson Schwartz, who has been a great leader in health policy. She's currently the CEO of the Better Medicare Alliance, where they do a lot of work focusing on Medicare Advantage and their beneficiaries. She spent a decade in the U.S. House of Representatives, really being a leader on public health and healthcare issues, and serving on 2 really crucial committees, the House Ways and Means Committee and the House Budget Committee. And that was after her really extensive career in the Pennsylvania State Senate, where she was one of the lead supporters of the original CHIP program, which then became a national model for healthcare for children. So welcome and thank you for being here. John McCarthy is with the Speire consulting firm and has over a decade of health experience, particularly in Medicaid. He was a former Medicaid director in Ohio and as well as DC, and is a really trusted subject matter expert to policymakers here in DC. And last but definitely not least, Dr. Dora Hughes, who is currently an associate research professor at the Milken Institute at George Washington University, formerly a policy advisor at Sidley Austin. And I looked at the years and I was like, where is it? You were really only 4 years in the Obama administration? That seemed like a long time. But I have a feeling it probably felt like with all the work that you did. And Dora was a counselor to HHS Secretary Sebelius on public health and essentially any major healthcare issue that was happening at that time, Dora was involved. And I was really lucky very early on in my career in Capitol Hill when I worked for former Senator Judd Gregg to work alongside Dora when she worked with both Chairman Kennedy as well as then Senator Barack Obama. So thank you all for coming. This is a really exciting panel, so please welcome our panel. So I want to start with a really big kind of broad question and give each of you a couple of minutes. From the policy perspective, federal, some state, what are some of the key policy initiatives that you're following as it relates to social determinants of health? We've talked today a little bit about what's happening at the community level, but at the broad policy level, what's going on that folks should really be aware about? Feel free to start.
All right, happy to start, and nice to be with you. I don't know if it's good or bad to be the final panel. Either you heard everything or you're ready to go home or you're really just still so into it that you want to hear what else we have to say. So thank you for staying and being here, and thank you to the Alliance for doing this. I'll start. The conversation about social determinants of health is one that both I feel like we've talked about it for a long time and in fact is just gaining some real traction in the real world of healthcare policy and healthcare delivery. I find that just even in the last 4 years or so that I've been at BMA, Better Medicare Alliance, that the conversation even within Medicare Advantage, which I'll talk about for a moment, but more broadly, is really coming to, just a higher level. The real attention to not just talking about social determinants, but really figuring out how that can be incorporated into the healthcare delivery system and into the payment and financing system. And I think that's really relatively new. I'm originally a trained social worker, so none of this is news to me. That was a really long time ago, and it's no surprise to me that if people are poor, if they don't have food, if they don't have transportation, if they don't have social supports, if they have functional limitations, they have a much harder time being healthy. And much harder time meeting their healthcare needs and participating in what they ought to be able to doing. And the healthcare system, we're well aware of. We used to say it was not really a healthcare system, it was a medical system. But we call it a healthcare system, but we really have, in very many ways, for many, many years, ignored health determinants and health services that are needed, social supports, and other kinds of health services. So what's exciting is that we are not only just talking about it, but really creating real opportunities to do something about it. I advocate now on behalf of an alliance of over 130 stakeholder organizations from health systems, health plans, from primary provider groups, through a lot of professional associations to community partners who are now really engaged on Meals on Wheels, area agencies on aging, providing social supports, in-home care, New York State Nurses, Visiting Nurse Association, suddenly they all are saying, we want to be in this discussion because we want to be able to be providing these services directly with healthcare providers. So what we have seen and what we see the conversation about is on behalf of this alliance, really advocating for two things that happened in the last year and a half that are game changers for Medicare Advantage. And a lot of what you're going to hear, I think, today, and probably have heard about all morning, is happening in Medicare Advantage. Sometimes people don't even mention that. But the truth is, if we don't change the financing system under Medicare, if we don't change it from paying fees for services for medical care to you can call it global payments, bundled payments, capitated payments is what we refer to. It doesn't change the real work that is happening within the healthcare system. But we're seeing that within Medicare Advantage, and we're seeing law change. We had both a bill that actually provided new flexibility to Medicare Advantage plans to be able to offer not only more and different kinds of supplemental benefits, but to do it in a way that was tailored to people with chronic conditions. What's really great about Medicare is you're supposed to do everything for everybody. What also isn't so great is actually there's some people who need more than others, and there's some people who have different issues, and that work should be able, and benefits should be able to be tailored specifically to those beneficiaries. Congress passed the Chronic Care Act. That was a really game changer in adding to the kind of supplemental benefits that are provided in Medicare Advantage. And these are, by the way, not any new dollars. These are dollars within the payment is essentially equal to fee-for-service, a set payment per member per month paid to Medicare Advantage plans based on and now equal to fee-for-service. But what they can do is move some of those dollars around. And they can reimburse for services not provided by traditional Medicare. That's where you get the supplemental benefits. They have to use those dollars for beneficiaries. They do. It was pretty narrow what they could provide. And now it's been opened up a bit for 2019, more for 2020. So we'll see what happens there. We'll talk more about that. But to really be able to provide benefits again to people with chronic conditions. And it turns out there are lots of them, as you know. Chronic conditions are the major issue for seniors today. Meeting the needs of people with multiple chronic conditions is the issue of how we get better care to better people, and for better cost for people. Better people too. They'll be better people. They'll be healthier anyway. But it is really meals we're talking about and nutrition. We're talking about transportation to appointments, huge issue for a lot of people. I'm talking about care in the home and home care aids, talking about respite care, talking about some home modifications, prevent falls, help people be safer. These are not medical services, but they are keenly important to having people be able to meet the needs and to follow protocols and to be able to get to see their providers. So we'll talk more about it, but it's a real game changer. It's a game changer, we hope, for Medicare more broadly. I hope we'll talk about that, about what else could be happening for everyone, because Medicare Advantage is 35% of Medicare, growing. Some people think soon to be 40%, but there's still 60% or in fee-for-service. They have some of the same needs that are not being able to be met. And I'll end there.
Yeah, great.
So in talking about the big picture and what's different going on now, it's interesting as if you're a Medicaid director, and Shannon McMahon was a Medicaid director, or Sandeep was, we're kind of chuckling because I've been doing this for 23 years in Medicaid, and 23 years ago, I was then consulting, helping health plans deal with these issues. So on the Medicaid side, that's been going on for a long time. When I was Medicaid director for the District of Columbia, I was with policy director and then Medicaid director, we were working on this under Mayor Fenty. Like, how do we get safer neighborhoods? Because we saw with kids poor health outcomes, and we were looking at things like exercise and different things like that. What you saw was they were in a neighborhood that was unsafe. And so we were working with the Department of Education of making sure that there was gym or physical education, something going on in the schools that helps making sure that kids able to get activity while they're in school, along with making sure they had breakfast, lunch, and then we were trying to figure out, could we get them dinners? And that wasn't through Medicaid, but that was how are we all working together and doing some of those different pieces. I also want to point out that in the Medicaid world, we've been doing the Money Follows the Person program for a long time. Ohio is one of the ones that has been doing this very successfully. And guess what it's around? Social determinants. It's helping people get housing, helping them get supported employment and other things that they need, and getting them on their feet. And it was for a subset of a population. I think the big change that you see now was the latest approval for North Carolina to use dollars on social determinants of health. And what you saw there is, if you really look at it, look at the Money Follows the Person program and look at the North Carolina waiver. Very similar in what they're doing. So it's an idea that they've taken and moved to a different level. I think the one interesting thing that's very different now, though, is you've got more people coming to the table saying, actually, let's try to figure out how to make this work together. Housing is obviously a big one that for a long time has been an issue. And I want to go back to the money follows the person waiver. In Ohio, for instance, we did very good at engaging people on the medical side. The issue we kept on running into is housing and lack of affordable housing and where do you have people live and dealing with that situation around that. That's for the individuals who happen to be on Medicaid. I think earlier somebody said that's one area, but it's the people above the Medicaid threshold. How are you working with them? I think that's another area that people are starting to talk about also.
Thank you. I want to thank Sarah for inviting me to participate on the panel today. I also want to give a shout out to Liz. We first met when she was assigned to work on minority health legislation by Senator Gregg way back in the day. And I was impressed at the time how genuinely engaged and interested she was in. So it's ironic that this is probably the first time we've been together in a work situation again, and we're talking about social determinants of health and health equity and minority health. So I suppose it all comes back around. I am just so excited to see this level of attention and awareness and, frankly, activity around social determinants of health. As my colleagues have said on the panel, this is an area that all of us have worked on for so many years, and it just really has accelerated over the past few years to levels of activity that are just thrilling to see. At George Washington University in the Milken Institute of School of Public Health, we are quite focused on accountable communities for health, ACHs, and I appreciate Dr. Koh's caution, let's not use too many acronyms, but I'll try to keep it at a minimum. We define accountable communities of health as multidisciplinary, multi-sectoral partnerships across public health, healthcare, and social services that are coming together to think about health more holistically. How do we treat not just the clinical needs, but also what about housing or food or utilities? How do we address whole person health as some people describe it? We have cataloged these ACHs, and we have identified more than 100 ACHs across the nation, across all regions, the north, the south, red, blue, purple states. They're all doing something very different. They've all formed. Sometimes it's been a shotgun marriage when these sectors have been forced to work together because the governor or the state legislator has said so. In other cases, they have formed organically in response to a local community need. The activities span the whole gamut of both healthcare focused to more public health focused. Probably, I would say the Accountable Community for Health ACH that's best known is the AHC model that the Centers for Medicare and Medicaid Innovation, CMMI, is sponsoring. It's over about 30 sites across the nation. But I think what's been important for all of us in this space is how can we learn from each other? How can we establish a community of practice? How do we evaluate? How do we even define this field? What is an ACH? And that is part of the genesis for the Funders Forum, which is housed at the School of Public Health. And the Funders Forum is a collaboration between six-ish federal agencies, CMS, CMMI, Medicaid, we have the Health Resources and Services Administration, or HRSA, we have the Centers for Disease Control and Prevention, CDC, we have SAMHSA at times, Substance Abuse and Mental Health Services Administration, and the Office of the National Coordinator of Health IT, ONC. The 6 federal agencies working with 6 foundations, the Robert Wood Johnson Foundation, Kellogg, Kresge, the California Endowment, Blue Shield California Foundation, Episcopal Health Foundation, all coming together to think through how do we define the field, how can we build upon each other's work in the area, how do we make sure we're not bumping into each other, how do we define it, like what is the best governance, how do we collect the data, what's the best portfolio of interventions that can be mutually reinforcing at a local level, and how do we engage community? All these different issues are hard. And it is really taking the expertise, the experience, and the leadership of the federal agencies working with state and local partners, as well as philanthropy and other foundation partners coming together to work this out. And so that is the area that I think we've learned a lot, both on the programmatic side as well as the policy side, and I think will help to inform some of our conversation today. Great.
Great, I'm going to do kind of a follow-up in reverse order. Within the context of the Founders Forum, Dora, have you experienced any types of barriers at the federal level to some of these agencies being able to either pool funding or for them to collaborate kind of outside of their own set lane in order to help with both individual interventions or also community level interventions?
Sure. I think that the financing is certainly a key issue across all ACHs. And what we're finding is in the earliest days, and most of the accountable communities of health, they are in the earlier stages. Even for CMMI, their AHC model, the accountable health community model, is only about in its third year of implementation. But what we're finding is at the broad level, you're able to get this grant, you're able to get foundation support to start the ACH. But then over time, that grant funding runs out. So how do you finance that in the long term? What are the sustainable sources of revenue? So that is a high-level issue that we are encountering. And different sites are tackling it in different ways. I mean, some are starting to think through how can we leverage Medicaid dollars? Can we get support through whether it's 1115 waivers or estate plan amendments? And I'm always careful, don't go too close. If you're sitting next to a Medicaid director, you should really just stop there. And, you know, or how can we leverage the MA dollars is another example. But we're also thinking through, if we look at categorical funding, if we look at some of the block grants through SAMHSA, for example, what services are covered and also what infrastructure support can be covered. And those are both getting coverage for the infrastructure and services are both key to long-term financing initiatives. Two other quick issues I'll mention. You mentioned braiding and blending. We're finding for many of the dollars, you can't pool the money together. It's got to be tracked to the individual beneficiary, which is fine when you're serving the individual, but many of the interventions that ACHs are taking on are at the community level. We have a Medicaid and a Medicare beneficiary, commercial payers. I mean, how do you pool the resources to address tobacco or asthma at the community level and overcoming some of the policy barriers? And one way that some communities are doing that are through wellness funds, wellness trusts. They're calling them different places in different ways. And that's been an interesting mechanism to, frankly, pool resources when allowable to address upstream determinants of health as opposed to thinking about the individual services. So I'll stop there, but certainly.
No, that's helpful. And John, I think, you know, you mentioned North Carolina. I think that was one of the goals that they had within their waiver was to try to get at some of these community level supports. You know, you mentioned that this is something that Medicaid directors have been thinking about for a really long time. You know, how are the states approaching it? Is this more of something that they would look to something like an 1115 to address in a holistic way? We've heard some things about needed changes with medical loss ratio and rate setting. How are states kind of approaching addressing this issue?
A couple of different ways, and I want to make sure that everyone understands the North Carolina situation was a very special situation. They got the dollars because they were able to prove budget neutrality under their 1115 waiver by moving from fee-for-service to managed care. That's where those dollars are coming from. Many, many states are already at managed care and using it, so those dollars aren't available. They don't have that same space to be able to do those things. So like in Ohio, where I was, or DC, both those places are around 90% of the individuals are being served through managed care already. So there's not that pool of dollars to go back to. So there's not going to be a lot of other states that are going to be able to do something like North Carolina is doing. So they're going to other places to look forward for dollars in different ways. Obviously, if you're using managed care already, you're looking at what's available there. The question is, do you need an 1115 waiver to do some of these services? Maybe if they're not traditionally covered Medicaid services, you can get a Medicaid waiver to do that and justify over the period of waiver that it's not going to cost the federal government more. I think one of the things right now that we have to be a little bit careful of is the economy is very good. So most Medicaid programs are generally seeing lower costs on the state side. So if you have that, there might be extra dollars to be able to put into different investments in these different areas. The question is going to be if a recession hits and things get tight, then where are the dollars going to come from? Because of the fact that it was said earlier on one of the panels, the return on investment on these investments are over long periods of time. Some of them happen quickly, but there's a lot that take a long period of time. So states are going to be looking at different mechanisms in 1115s. Can they get dollars? Can they get the federal government to agree to pay for some things, assuming that we're going to get savings over some period of time, specifically the 5 years for the waiver?
And in the context of Medicare Advantage, Congressman, you mentioned that there may be some new flexibility around supplemental benefits a little bit in the 2019 plan year, but a significant amount more, according to some folks, in plan year 2020. What's your sense of how plans are viewing that and thinking through what they can do in this space? What's the reaction been?
It's not just plans, it's also the providers, and it's actually some of these community partners who are asking the very questions that sort of raised, which is, wow, there are all these dollars, can I get some of them? Which there may be some dollars, but it's really, I'll answer it this way. And I wanted to mention on the whole issue of Medicaid, which has been doing managed care for a long time in states. And of course, I look at it now as the dual eligible population, so it's Medicare and Medicaid. That helps a lot for that population because they have the Medicare benefits and they get some of these supplemental benefits through Medicaid. However, some states do a whole lot better job of really integrating those two programs and really working together. Some have actually used managed care. I'm from Pennsylvania, which has been doing managed care under Medicaid for a long time. But there's still a difference when we're finding this in Medicare Advantage more broadly. There's a difference between taking the plans, getting a capitated payment, and then really using it at the provider and delivery system level. And that's, because they would be providing care management, some wraparound services, so to speak, in that way. But it's when they really engage with providers and have them particularly taking risk, taking financial risk, getting capitated payments for the part they do, is when they start to say the dollars saved come from the care coordination, reducing unnecessary services, primarily comes from reducing hospitalizations, avoidable hospitalizations, getting people out of the hospital sooner, providing home care, keeping them out of institutions. It's those dollars that then can be reused to actually provide different kinds of services. And I think that's when we start to see some of our provider groups working under Medicare Advantage really saying, wait a minute, I have full responsibility for all of the not only the providing the benefits, but I'm held accountable also for the outcomes. Then I start to think about it, what can I do differently? Does it make sense for me to send somebody, and hospitals have done this some as well, does it make sense for me to send somebody into the home post-hospitalization? Does it make sense to provide meals, but program that provide 20 meals for the 20 days post-hospitalization to frail elderly who are isolated, who are at home? Turns out it reduces hospital readmission rates by very big numbers very quickly. So then, so those dollars then, they say, well, we're going to do more of that. Maybe we should provide meals for a little bit longer, hence the new flexibility and nutrition. What kind of supports does someone need over the long term to be able to get the kind of care? But all of this is still pretty, some of it's been done for a while, but it hasn't been scaled up to the degree that you can say, wow, it's going to be everywhere, you're going to see it everywhere. There's still limitations from CMS. These dollars are supposed to be used for people with multiple chronic conditions. So we look at, well, what does that mean? Can you really measure functional limitations? That doesn't really count as a chronic disease, but it can exacerbate the chronic diseases. And now beginning to look at, should we measure that? Does it help us identify? This is a big thing that's happening under Medicare Advantage. How do we identify these particular beneficiaries who may come to the doctor's office or may not, or may show up and say, I'm just fine at home. Turns out they're really not so fine at home. They really no longer really shop. They no longer really cook for themselves. They don't eat dinner at night. They're not being able to get to the pharmacist. Their pharmacist doesn't deliver, so they're not sure who to call. They don't want to call. They don't want to, so it's really taking the reality of those individuals' lives and really addressing the services they need. Some of that will happen in 2020. We will see some plans testing out what works, trying to figure out who on the care team. We know the primary care teams really matter. Who on the care team really is looking at that? Who's assessing it? Has someone been in the home and identified what the needs are? How do we build that into the work we do? And again, how do we identify those high-risk, high-need patients who are somewhere between 1% and 5% of the Medicare population? To your point, some of them are dual eligible, already poor, identified under Medicaid, but some are near poor, and they don't get those extra benefits under Medicaid. And under Medicare Advantage, the average income for a Medicare Advantage beneficiary is $24,000 a year. Now, some of these people may even own their own home, but they're living on very little money. They have very little resources, and many of them are isolated and alone. So what kind of support do they need and should be getting? So I think we're looking at plans picking up on these flexibilities, but they are going to be looking for the return on the investment. What keeps you out of the hospital? What keeps that person out of the hospital? What combination of these benefits make a difference? Because otherwise you're going to be in the same place as some of the community partners are saying, where does the money come from? They have to provide the benefits that are guaranteed under Medicare. But they're interested in this. They know it. They've seen it make a difference. They want to make a difference. Long term, you hope that this actually builds in to the Medicare program that this matters, meals matter, nutrition support matters, or transportation should be paid for, and become a part of a standard Medicare benefit, or at least within Medicare Advantage, because that won't, that could be done, or maybe across all of Medicare. So I think we're on the cusp of really figuring out, of testing it out and seeing what works, and to see how broadly it is done and the difference it kind of makes. And we're seeing that, I'm going to talk more about really going into poor, underserved communities where beneficiaries still go to the ER because, in fact, there are no doctors in their neighborhood to go to. And so it's a reasonable choice to make. But in fact, if you place a health center in that community, okay, that makes sense. Maybe they will come to us. But then encouraging them to change that behavior, to not show up in the ER, to actually think about having a primary care practitioner and developing a relationship with the healthcare system that can help them navigate what is really a quite confusing, fragmented healthcare system otherwise.
This is kind of for anyone. In a number of the panels throughout the day, we heard a variety of different folks talk about anchor organizations or the need at a community level to have some type of anchor institution that was really helping organize members of the healthcare system, the social services system, to really try to figure out whether it's pooling funding or trying to address some of the interventions that are community level. So understanding that community activity really is a key to having a sustainable approach. What are some of the things that the federal government can do with its powers and limitations to help support those activities, both, whether it's financially or, how do you create the governance or best practices for those types of activities? Openness to anyone.
Well, I'll just be, you probably, go ahead.
I will always defer to a congresswoman, so.
I was just going to add quickly that I do think that one I just mentioned, I do think that the federal government could do more. This happened under the special needs plans reauthorization to really, to create an office for coordinating Medicare and Medicaid. I think that would be useful. Secondly, I think that as plans do start, and providers under Medicare Advantage and community partners start to learn what works and what doesn't, for CMS to actually share some of those best practices, to share the lessons learned, so that every community doesn't have to, well, they'll want to figure it out for themselves, there'll be variations, but to learn something that's been done before. As you point out, people have been doing this for a while, let's figure out what really works. How much community support do you really need? I've seen locally some hospitals really trying to work together, particularly those who are seeing a very poor population, trying to build up some of those community resources. We've seen all sorts of innovation in the private sector as well, everything from the technology of remote monitoring to supermarkets having clinics inside their supermarkets, because that's where people are at 5 and 6 and 7 o'clock at night. So I think we're going to see a real variety of more convenient, more community-based services. And the last thing I would say is, I think the federal government could help some of these community partners actually have a technical support of how do you actually work in a more entrepreneurial way. I know the area agencies on aging, they've relied for a long time on the Older Americans Act and grants. Something they say, I have to now negotiate contracts with insurance plans? Who in my office does that? No one does that. Who has the expertise to help us do that? And help them actually be able to meet, as I say, CMI could do it, but others could really say there is some workforce development here that is also needed. So I think that would be the final point, is that there are probably not enough of those new kind of social support services and the workforce that's needed to actually be in the community, be in the home, to provide this kind of care.
So I was going to say, in our review of Accountable Communities for Health, or ACH, we're seeing a whole range of entities that are serving as the anchor institution or the backbone organizations. In some cases, the public health department. In some cases, it's community-based organizations like a United Way. In other cases, the hospital or community health center. But what I think a key issue is that it has to be an institution that has strong relationships with the community and is well regarded, can be a neutral arbiter, will put the needs of the community ahead of its own specific needs, particularly when it comes to funding. One of the issues, and I think that to your point, how can the federal government be helpful, is frankly around funding again. There's a lot of infrastructure activities that this backbone organization has to do. It has to engage the community. Who pays for that? It has to convene all the different stakeholders. Who pays for that? It has to have a facility where they can meet. It has to collect the data. It has to have the IT systems. It has to manage and sometimes evaluate grants. All of those infrastructure activities are extremely important to an effective, accountable community of health and must be financed. And I think that the government can play a role in helping with that. For example, you can pay for services out of certain grants. Can you pay for some of these infrastructure activities? And in that case, how do you do that? Does it have to be through overhead? Does it have to be through administrative claims? Can you use actually direct funding for that? And sometimes when you think, okay, it can be part of the overhead costs, well, sure, but that's also where you pay for rent and the phone service and salaries of the employees. So there's a lot of hard costs that have to be paid for that are competing with some of these other infrastructure functions, such as the convening or the community engagement, that are also critically important. So I think that the federal government could clarify how these types of services, the infrastructure activities, can be paid for. And I also think that that is a role for the private philanthropy as well.
Dora, based on your experience working at HHS, one of the things I think we've seen, a lot of the things we've talked about so far are HHS, what they're doing in Medicare Advantage, HHS, what they're doing with CMMI, what they're allowing states to do through Medicaid. How, from a federal approach, do we make this less of just a healthcare exercise? What are some ways where, based on your experience, you can get HUD, AG, other, interagency collaboration? Is that happening? What are some thoughts in that space?
Certainly, and I could think of a number of examples. One, when we were working on obesity as part of the First Lady's Let's Move campaign, we worked very closely with the Department of Agriculture and the Department of Education to think through what were some of their policies, some of their mechanisms. And of course, I was, as one of my colleagues at AG pointed out, I always like to pick other people's pocket. Other departments have much bigger budgets than HHS, and it was another excellent incentive to collaborate very closely. We also have looked at, I remember when we were looking at tobacco, smoking cessation policy, we worked with the Department of HUD to think through how can you have green housing, or what kind of policies can we put in place as part of your housing policy. So we're providing the services on the HHS side, and you can provide the incentives for those for residents to seek out those services. So I think it's possible. I think it's been done, and it's been done at a large scale. I will note that CDC recently held a conference to look at community clinical linkages of care in February, and I was cheered to see HUD was in attendance, as well as a couple of other federal departments. And so I think at a high level, they are starting to think through how can we do this together that I expect will be fruitful in the long term.
And John, what's your experience as a Medicaid director with dealing with a local state public health agency, the governor's office? How have you seen at a state level, some of this interagency work?
Not very well. So
That's an answer.
this is one of those areas, a lot of tension in a lot of different places, mostly because Medicaid is looked at as you have all the money, just let us have some of that money. And of course, the Medicaid director saying, yes, I have this money, but it's tied to a lot of strings. And I used to talk to my sister agencies and say, if you want to come and feed from the Medicaid trough, there's a lot of strings attached to it. You really want to have to do all these things. And you've seen this happen, a lot of different programs, and Medicaid in schools programs, a number of states that had big audit findings around there. So the issue is, how do you make that balance of understanding what goes together? The other thing that's very difficult is picking winners and losers on some of these different pieces. And so you were talking about earlier, like the federal government getting in and grants and different pieces like that. We did this in Ohio at a very small level through Medicaid, working on infant mortality. And it was very interesting. We went into the community to talk to individuals to figure out how we could get them the money that we were going to push out through our managed care plans. And there was often distrust for the local Department of Health. And it was often an equity issue that we were running into. And so, coming up with who's the anchor organization is not always easy to figure out who the right anchor organization is and how do you work with them. And then back to what I was saying before, Medicaid dollars or all federal dollars, whether it be grant dollars or Medicaid dollars, there's a lot of audits that come with them, a lot of how do you use the money in different pieces, and the CBOs aren't ready to do those and understand what comes from those. I'll tell you, as a Medicaid director, the number of times people came in and said to me, if you just gave me $1 million, I'll save you $200 million. My program should have cost zero because I would have had all these savings out of it. It doesn't really work that way. And then also one of the issues that you run into is when you do this and you do the outcomes, you measure outcomes, if a program doesn't work, that's been around, let's say for 20 years already, and then you're the one telling them, I'm going to turn this off, they'll point to some data that they have of why their program works. So that's how the current system works. So I think that's another area that we run into issues when you're looking at the Department of Public, if you're looking at public health versus Medicaid versus some of the others, is what is the outcome you're looking for? What is a positive outcome? And do all the different federal funders agree that that's a positive outcome that you're seeing?
We hear, at NASDA, we do a lot of outreach on the Hill, and we're starting to see more activity from a couple different congressional offices. But I think one of the questions we hear a lot is, what is this SDOH thing, and what am I supposed to do about it? So, Congresswoman, if you were still on the Hill, you have a room full of people here that are really interested in this issue and want to see. Even if we're not yet at policy proposals, want to have our federal policymakers engage. What's the type of information that they should be bringing to their members of Congress to help make this a priority? And what type of tools, if you were in that spot again, would you want to be hearing about?
Well, I think, and this is not going to be news to anyone, I think in this audience, but is that increasingly the federal government is asking for evidence of what works. And you're absolutely right, it's hard to get rid of programs sometimes when they've been around just because there's institutional support for them as well as congressional support for them sometimes. But certainly when you're talking particularly about healthcare dollars and about social determinants of health, which this still is, it really is a question of which of those make a difference in terms of improving outcomes. And what do we mean by outcomes? Is it keeping people out of the hospital? Is it actually improving health status, which should be the long-term goal? Is it helping people to manage their conditions and to live healthier lives? And so I think it has to be targeted in conversation in terms of the goals and how we get there. But then I think there has to be, well, I sort of believe in using the private sector, ability to actually, where they do have more flexibility than the federal government sometimes has. The federal government can say, they do sort of with Medicare Advantage, but they should be doing with this new area of social determinants of health and how it affects health outcomes. That is really the question. Because when everyone nods that in fact it's outrageous that there's hunger in America, but then doing something about it, you need to be more concrete. So, and there are a lot of different ways to do it, but tied to healthcare, there's some very concrete ways we can do it. And I think we would say again, right now there is this avenue through Medicare Advantage. We should make use of that. It's lessons can be learned from it. But it is, we still recognize that still most Seniors are still in traditional Medicare. How do we actually make sure that they reap the benefit as well from lessons learned in Medicare Advantage? Maybe that's growing Medicare Advantage, and that's happening through the popularity of the program with beneficiaries. But to really understand that if this extra benefit works that well, again, it works well because it's in an integrated system. It's not an add-on. It's not separate from. And that does not to diminish the fact that delivery of meals isn't important by itself, but the fact that you want to influence the health outcomes, you also need to close those silos by making some party responsible. And in this case, it's the Medicare Advantage plans who are responsible for figuring out, is this worthwhile, is it not, how can we do it? But we're really on the cusp of having the federal government do it. Members of Congress should support these incentives. They should allow for that kind of flexibility. They should demand accountability because it's federal dollars, but they should, and they should align some of the goals. Your point is well taken. Even the measurements that exist under so many of the Medicare and Medicaid programs are slightly different or really different. So, you should really be able, they've been talking for years about we're always going to align these measurements, we're going to reduce the burden administratively, and that doesn't really happen. So some work around that. And again, helping to build the infrastructure on the local level, I think is, I would endorse that, because not everything can be done, nor it will be done through Medicare and Medicaid.
Well, we are at time, but thank you all so much for all of your comments, and hopefully we've given you some ideas to think about.
Thank you so much. This was fantastic. And John, if you give me $1 million, I will tell you it's lunchtime. It's lunchtime. I'm sorry that we are out of time for questions, but I want to thank everyone for coming. Please, please, please fill out a blue evaluation form before you leave. We really do use it for future programs. And I think Krista Drobak gave you a homework assignment to find somebody who does not work in the healthcare sector, find someone in a different sector, and take them out for a coffee. And I will add one more, which is please save the date for September 13th, when we will be doing the next piece in this series on social determinants of health. We will have a congressional briefing, so taking it right to Capitol Hill, and we're going to be focusing on financial alignment and some of the financing mechanisms that we've teed up today. So again, I want to thank every single panelist and moderator. Thanks to everyone in our audience, and thanks to everyone who supported today's summit. Have a great day. Bye.